بسم الله الرحمن الرحيم. السلام عليكم طلبتنا الأعزاء. In this third lecture of the cardiovascular disease, we will continue with congenital heart disease. In the last lecture, we finished the discussion of the acyanotic congenital heart disease, including ASD, VSD, patent ductus arteriosus, and coarctation of the aorta, and we discussed the most common cyanotic congenital heart disease in the children with oligemic lung fields, the tetralogy of the Fallot. And today we will discuss the most common cyanotic congenital heart disease in the newborn, or the most common cause of cyanosis in the newborn, which is the transposition of the great arteries, or what we call TGA. It is account for 5% of all congenital heart disease, and it is the most common cyanotic disease present in the neonatal period. حكيت في المحاضرة السابقة قلت التوف it is the most common cause of cyanosis in the infancy or childhood, while it is not present with cyanosis in the neonatal period, and the most common cyanotic disease in the neonatal period هو التترالوجي of the Fallot. In the tetralogy of the Fallot, the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. على عكس الطبيعي، بالطبيعي هو aorta arises from the left ventricle and pulmonary artery arises from right ventricle. هنا normal heart نشوف right pulmonary artery it arises from the right ventricle and aorta arises from the left ventricle. So the systemic venous return to the superior vena cava and inferior vena cava goes to the right atrium, then through the tricuspid valve to the right ventricle, then it will be pumped to the lungs through the pulmonary artery, where the gas exchange is done and the oxygenated blood return from the lung to the heart through the pulmonary vein to the left atrium, then through the mitral valve to the left ventricle, then it will be pumped into the body by the aorta. So it is series circuits. While in the TGA, what's happened? The deoxygenated blood, which is retained from the systemic circulation through the superior vena cava and inferior vena cava, goes to the right atrium, then to the right ventricle, then it will be pumped again to the body through the aorta without reaching the lung for gas exchange. So it will remain deoxygenated, rich by the CO2 and without oxygen or very little oxygen, and will be back to the body. While the oxygenated blood, which comes from the lungs to the heart through the pulmonary vein, oxygenated blood, it will be enter to the heart through the left atrium, then left ventricle, then it will be pumped again through the pulmonary artery to the lung. So the deoxygenated blood, which comes from the body through the superior vena cava and inferior vena cava, it is returned back as deoxygenated blood to the body through the aorta. يعني بقى احنا على نفس حاله. والاوكسجينيتد blood اللي comes from the lung through the pulmonary vein to the heart, it will be pumped again to the lung as oxygenated blood through the pulmonary artery. So without mixing between the two circulations, the baby will be died immediately. ماكو gas exchange. الديوكسجينيتد blood يجي من الجسم يرجع للجسم as deoxygenated، والاكسجينيتد blood اللي يجي من اللنج يرجع لللنج as oxygenated blood. Without mixing, this unsuitable for life. The mixing might be occur at the arterial level through the patent foramen oval, or arterial septal defect, أو in the ventricle level through the VSD, أو at the level of the great arteries by the patent ductus arteriosus. إذا ما عندي patent ductus arteriosus أو patent foramen oval أو ASD أو VSD, the baby will be died immediately. Clinical features, how the baby present. Cyanosis, it is always present, and its severity depend on the amount of the mixing between the systemic and arterial circulation. كل ما يكون السيستميك والارتيريال الميكسينج between arterial and systemic circulation good، كل ما يكون الساينوسيس better والبيبي كان live for period. تكبنية أكيد تصير، و single S2 and there is no VSD, and if there is no VSD there is no murmur. Children with TGA and large VSD may present with sign of heart failure due to the severe shunt with palpable left and right ventricular impulse, single S2 and loud VSD murmur, pansystolic murmur. Sorry. Diagnosis is by ECG, which shows right axis deviation and right ventricular hypertrophy, and chest X-ray will show increased pulmonary vascularity due to the presence of the shunt, and egg on string caused by narrow superior mediastinum. Egg on string بيضة معلقة بخيط caused by narrow superior mediastinum. هاي نشوفها هنا عندنا narrow mediastinum، فايش راح يصير؟ الهارت as egg on string. This is the cardinal sign for the TGA. Echocardiography أكيد will be demonstrate the definitive diagnosis by presence of the transposition of the great arteries, site and amount of the shunt. راح يشوف لنا if there is ASD, VSD or PDA, or any associated anomalies if it is present. Treatment طبعا أكيد immediately you must maintain patent ductus arteriosus for the mixing of the blood. تحقق لك degree من المixing of the blood until the definitive surgery is done. Until definitive surgery is done. فلازم أول مرة create shunt by the create mixing by the maintenance the ductus arteriosus by infusion of the prostaglandin E1 immediately after birth to maintain the patency of the ductus arteriosus and allow mixing of the blood. Balloon arterial septostomy done if there is no response to the prostaglandin infusion. إذا ماكو prostaglandin والبيبي بعد ما محضر للأوبريشن by the balloon راح نفتح الارتيريال septum، يعني نسوي ASD for the mixing of the blood, and complete surgical repair by arterial switch operation. هاي هي correction، يعني يقصون الأورطة و reattach to the left ventricle والpulmonary artery reattach to the right ventricle. It is usually done within the first 2 weeks of life. Now we finished the congenital heart diseases, the main congenital heart diseases which might be faced in your practical life. And now I will shift to the acquired heart diseases. In the acquired heart diseases, I will concentrate about 2 important diseases, which are the infective endocarditis, and in the next lecture, inshallah, we will discuss the acute rheumatic fever. Infective endocarditis, it is include acute and subacute bacterial endocarditis, or less commonly non-bacterial endocarditis caused by viruses, fungi, and other microorganisms. It is a significant cause of the morbidity and mortality in children and adolescents, and it is often complicated congenital heart disease or rheumatic heart disease and prosthetic heart valve, but it can occur in children without any cardiac abnormalities or what we call native heart. Pathophysiology. The infective endocarditis is a consequence of jet stream of turbulent blood flow through the BDA, VSD or systemic to pulmonary shunt يعني collateral. هذا راح يسوي jet stream قوي يعني of the turbulent blood flow. فهذا ايش راح يسوي لنا؟ vascular endothelial damage, which is vascular endothelial damage, and this will be cause the non-bacterial thrombotic emboli, which is thought to be the initiating lesion for infective endocarditis. يعني jet blood flow occur or turbulent blood flow راح يصير لي vascular endothelial damage, والvascular endothelial damage راح يصير لك non-bacterial thrombotic emboli, then get infection which is caused acute bacterial endocarditis. Predisposing conditions for or factors for the acute and subacute bacterial endocarditis, including prior congenital or rheumatic heart disease, preceding dental, urinary tract, or intestinal procedures, intravenous drug use, central venous catheters, prosthetic heart valve. These are the main predisposing factors for development of acute or subacute bacterial endocarditis. Causative microorganism, الetiology عندنا Streptococcus viridans and Staphylococcus aureus. These are the most common causes of acute and subacute bacterial endocarditis. Other microorganisms, including Streptococcus pneumoniae, Haemophilus influenzae, coagulase negative Staphylococci, and fungi are less common than Streptococcus viridans and Staphylococcus aureus. Blood culture is negative in about 6% of the cases. يعني 6% من الكيسز ما لقوا عندهم أي bacterial cause, وهذا might be due to the immune mechanism, autoimmune mechanism, or other. It is unknown. Clinical features, symptoms. طبعا السيمتومز عادة بالسبكوت أو acute bacterial endocarditis تكون non-specific and required common sense. يعني لازم تكون suspicious يعني suspicion يقعد لها. in the early there is mild prolonged fever with occasional weight loss, or acute and severe onset with high intermittent fever and prostration. طفل يضل يتعرق هواية. non-specific fatigue, myalgia, arthralgia, headache, chills, nausea and vomiting, chest and abdominal pain, dyspnea, night sweating, and CNS, stroke and seizure. كلها non-specific manifestation. شوفها mild prolonged fever and occasional weight loss. It is a lot of causes for it. Or the baby had high fever with prostration, ضل يتعرق هواية, أو non-specific fatigue, myalgia, arthralgia وغيرها. الساين يصير عندي elevated body temperature, tachycardia, petechiae, new or changing heart murmur. بصراحة this is the clue for the suspicion of acute or subacute bacterial endocarditis. عادة إذا البيشنت عنده prolonged fever, weight loss, or non-specific manifestation, و develop a new or changing heart murmur وهو عنده predisposing factor, prosthetic valve, valvular heart disease, congenital heart disease, فهنا أقول هذا البيشنت عنده subacute bacterial endocarditis. fever, prolonged fever, low grade أو high fever, زين، و non specific manifestation، وصار عندي new or changing murmur. a patient who previously with congenital heart disease, prosthetic valve, surgical operation, previous surgical cardiac operation, أقول هذا البيشنت صار عنده bacterial endocarditis. Splenomegaly is common. Signs of the heart failure and arrhythmias, clubbing of the fingers, while metastatic infection like arthritis, meningitis, mycotic arterial aneurysm, pericarditis, and cardiac abscess. And also septic pulmonary emboli. Also, there is classical skin signs, which are developed later in the course of the disease, and they may be vasculitis caused by circulating antigen-antibody complexes. These signs are oslar node, which is tender, B-size, get the fasulia, intradermal nodules in the pads of the fingers and toes. Here, oslar node, اللي يكون tender, B-size, intradermal nodules in the pads of the fingers and toes. Other general lesion, which is painless, small, erythematous, hemorrhagic lesions on the palms and soles. Small, painless, هناك tender، هنا تكون erythematous or hemorrhagic، هناك تكون B-size مثل الفاصوليا on the palms and soles. Also, we have splinter hemorrhage, which is linear lesion beneath the nail. Linear hemorrhagic lesion beneath the nail, which is called splinter hemorrhage. Diagnosis of the subacute bacterial endocarditis, especially or acute, it is blood culture. Blood culture is the main way for the confirmation of the infective endocarditis. بصراحة blood culture هنا required certain attention. أول شيء 3 to 5 blood samples should be obtained after perfect sterilization of the skin. Perfect sterilization of the skin, it is very important because the bacteria which are contaminated the skin, usually contaminated the skin, like especially Streptococcus viridans, might be the causative agent for the infective endocarditis. فأنت إذا ما مسوي good sterilization of the skin احتمال هذا هو contamination of the skin وأنت اعتبرته هو causative agent of the agent for the subacute bacterial endocarditis or infective endocarditis. فرجاء perfect sterilization by alcohol, it is very important and required 3 to 5 blood samples. Causative agent is recovered from the first 2 blood culture in 90% of the cases. تحتاج 5 مرات يمكن أن تعيده. The bacteremia is low grade. Bacteremia is low grade in 80% of the cases. يعني شنو؟ less than 100 colony unit per mole of the blood. لذلك causative microorganism might be not discovered by usual blood culture procedure. So the lab should be notified that the bacterial endocarditis is suspected. Infective endocarditis is suspected. So the specimen of the blood cultured with enriched media for longer duration, usually more than 7 days. عادة احنا الكلتشر 3 days وناخذ النتيجة مالته. بس إذا أنا I suspect infective endocarditis, I should notify the lab that I suspect this infective endocarditis, so the blood sample will be cultured in the more enriched media and for longer duration, more than 7 days, because the bacteremia is low grade. يعني مو هواية الcolonies in the blood, it is less than 80, it's less than 100%, so 100 colony units per mole of the blood. طبعا عندنا بعد elevated of the ESR and C-reactive protein, which is non-specific inflammatory markers. Complete blood count will show anemia of the chronic disease and leukocytosis due to the infection. Immune complexes detection because it is antigen antibody complex because it immune modality, and positive rheumatoid factor also, this is not specific here, and general urine shows hematuria because the nephritis, it is very common with infective endocarditis. And sometimes even nephrotic syndrome developed. Echocardiography will be shows evidence of valve vegetation, prostatic valve dysfunction, myocardial abscess, and new onset valve insufficiency. Complications of the infective endocarditis: heart failure, which is most common due to aortic or mitral vegetation. Systemic emboli will be cause CNS and pulmonary pulmonary emboli, which might result in the stroke or pulmonary infarction. Myocardic aneurysm, valvular obstruction by large vegetation, and acquired VSD, مرات السبتم rupture فيصير acquired VSD, and heart block due to the involvement of the conducting system. Other complications: meningitis, osteomyelitis, arthritis, had a metastatic infection, renal abscess, and immune complex mediated glomerulonephritis. Treatment. طبعا antibiotic therapy, it is the cornerstone for the treatment of the infective endocarditis and should be started immediately once the diagnosis is made. يعني هذا عندي أنا suspicion of the infective endocarditis depending on the history of the prolonged fever, night sweat, weight loss, non-specific manifestation, or development or new murmur or changing of a previously present murmur. Okay, in patients with risk factor including the prostatic valve, congenital heart disease, arteriopulmonary communication by the shunt, palliative shunts or the PDA, then and other risk factor. فأقول هذا البيشنت have infective endocarditis and should be start antibiotic therapy immediately. The empirical antibiotic therapy, empirical I mean it is before result of culture, include vancomycin 40 mg per kg per 24 hours in 2 to 3 divided doses, plus ceftriaxone 100 mg per kg per 24 hours once daily. Then the antibiotic therapy should be continued for 4 to 6 weeks and modified according to the blood culture result. أول ما أبدي empirical قبل لا أحصل الculture قلنا الculture might be remain for more than 7 days. So at this period I will start empirical therapy by the vancomycin and third generation cephalosporin. بعدين modification according to the results of the blood culture. If the cause is streptococcal virulence, so the drug of choice is a crystalline penicillin 200,000 unit per kg per day or ceftriaxone. If the patient is sensitive to the penicillin, then give ceftriaxone plus gentamicin or vancomycin. فإذا عندي streptococcal virulence أول ما أبدي هو drug of choice crystalline penicillin plus أو ceftriaxone. إذا البيشنت sensitive to the penicillin نعطي ceftriaxone plus gentamicin or vancomycin. If the cause is staphylococci, then the drug of choice is nafcillin or oxacillin for 6 weeks plus gentamicin for 3 to 5 days optional. يعني gentamicin يمكن تستخدمه أو ما تستخدمه according to the case. But for the drug of the choice for the staphylococcal infective endocarditis هو nafcillin or oxacillin. If the patient is allergic to the penicillin, then giving ceftazoline for 6 weeks plus gentamicin for 3 to 5 days. Also, it is optional. And if the patient is infected by oxacillin resistant strain, then vancomycin for 6 weeks. فإذا كان ستافيلوكوكاي وما عنده أي resistance ولا sensitivity نعطي نافيسيلين or oxacillin with gentamicin optional. If that patient allergic to the penicillin, لا نستخدم السيفتازولين plus gentamicin also optional. And if the patient infected with oxacillin resistance, نعطي الvancomycin for 6 weeks. هاي very important رجاء the type of the antibiotic and its duration. Very important. Treatment of the heart failure by the diuretics, afterload reducing agent, digoxin. Afterload reducing agent نقصد بها الكابيتوبرول والديجوكسين وهي راح discuss in the lecture of the heart failure. The prevention. Prevention is very important. Previously, antibiotic prophylactic therapy was recommended for any patient at risk for development of infective endocarditis before doing any dental, gentamicin, or lower GI tract procedure. قبل أي واحد عنده risk for development of infective endocarditis يعني عنده prosthetic valve, عنده previous cyanotic congenital heart disease أو previous cardiac surgery ويريد يسوي dental, genitourinary or lower GI tract procedure should take prophylactic antibiotic. Nowadays, the prophylactic antibiotic indicated only before dental procedure. شافوا الريسك ويدنيش قليل فخلوها بس ويا الdental procedure in patients with cardiac condition which are associated with poor prognosis of infective endocarditis which are included. يعني indication of the prophylactic antibiotic in the patient to prevent infective endocarditis in the patient with dental procedure إذا كان عنده prosthetic cardiac valve, إذا there is a previous infective endocarditis, إذا there is congenital heart disease, unrepaired cyanotic congenital heart disease including palliative shunt مثل جماعة التوف أول ما نسوي لهم palliative shunt then corrective surgery أو completely repaired congenital heart disease with the prosthetic material during the first 6 months after the procedure أو repaired congenital heart disease with residual defect at the site of or adjacent to the prosthetic device, or there is cardiac transplant recipient, or there is permanently damaged valve by the rheumatic heart disease. These are conditions which are required prophylactic antibiotic before any dental procedure. يعني tooth extraction or other procedures. How I will do the prophylactic antibiotic regime for dental procedure, this is very, very important to be known. هاي لازم تنحفظ بأسماء الانتيبيوتيك بالدوزز مالتها بالضبط لأنه very important. يعني أنت باكر يمكن قاعد بمركز صحي وبيشنت يريد يقلع سنه ولازم تعرف يعني. فعادة نعطي oral amoxicillin 50 mg per kg usually within 1 hour prior to the procedure. أو that patient is unable for oral intake يعني severe abscess عنده أو هذا any cause هنا شو راح نعطيه؟ راح نعطيه ampicillin 50 mg per kg IM or IV هنا within 30 minutes period short. الأورال within 1 hour بينما الIV or intramuscular ampicillin نعطيه within 30 minutes prior to the procedure. Or ceftriaxone 50 mg per kg IM or IV also within 30 minutes of procedure. And patient allergic to the penicillin and able for oral intake. هسه صار عندي أول مرة البيشنت take oral can't take orally and without any allergy نعطي amoxicillin 50 mg per kg أو أي amoxicillin 50 mg per kg within 1 hour of procedure. لا والله البيشنت مالتي unable for oral intake ما يقدر ياكل أعطي ampicillin 50 mg أو ceftriaxone 50 mg per kg intramuscularly or IV 30 minutes prior to procedure. إذا البيشنت allergic to the penicillin and able of oral intake إيش راح أنطي سيفالكسين الكيفلكس 50 ملغ بير كي جي أو أعطي كليندامايسين 20 ملغ بير كي جي أو أعطي أزيثرومايسين أو كلاريثرومايسين usually 15 ملغ بير كي جي 15 ملغ بير كي جي. إذا البيشنت allergic to the penicillin and unable of oral intake هنا إيش راح أعطي سيفترايكزون 50 ملغ بير كي جي intramuscular or IV وأرجع وأقول الأورال 1 hour to the procedure prior to procedure and the IV or intramuscular 30 minutes prior to the procedure. فسيفترايكزون أنطي كليندامايسين 20 ملغ بير كي جي intramuscular or IV. إذا بالبروفيلاكسيس إذا بالبروفيلاكسيس عندي 4 حالات. اما هو يقدر ياخذ اورال وما عنده اي الرجي اعطيه اموكسيل، او ما يقدر ياخذ اورال وما عنده الرجي اعطيه امبيسيلين او انتراماسكولار او ار في او انتراماسكولار او ار في سيفترايكزون. لا، البيشنت يقدر ياخذ اورال but allergic to the penicillin اعطيه سيفالكسين كيفلكس او كليندامايسين او ماكرولايتس اللي هي ازيثرومايسين او كلاريثرومايسين. إذا البيشنت allergic to the penicillin and unable for oral intake هنا راح أعطي سيفترايكزون أو أنطي الكليندامايسين. هاي very important to know the indication of prophylactic antibiotic and details of the prophylactic antibiotic. بقت عندنا البروجنوسيس of the infective endocarditis. هي mortality rate is very high 20 to 25%. And the serious morbidity occur in 50 to 60% of the patient despite of the appropriate antibiotic therapy. And thank you very much for your nice attention. And please, if you have any question, please contact me with my pleasure. Thank you very much.